Chewe is going to give an overview of the findings from the bottleneck analyses in each of the 4 project countries.
Thank you. Hope I can move this. I think we all saw this on the first day of this conference. Eric Gooseby actually presented this, and Craig McClure has also alluded to the fact that since the release of the update in last year in April by WHO endorsing option B as an option for PMTCT, as an optimal option for PMTCT, we've seen a mushrooming of countries deciding to move into this direction. And trust me, we're getting a lot of requests from these countries around how to do it right. So they're not looking at the regimen shift as the only thing that they need to do, but they're also looking at how do they do it and what is the best approach. And we talked a lot about the cascade response here yesterday as I was sitting and listening. I said, yes, this is exactly how we're starting to look at what we have to do for PMTCT, because within PMTCT we have many cascades. And for us, the limitation really is the MNCH platform, maternal newborn child health platform, how it's performing at this moment in most countries, and how then the PMTCT cascade is actually related to that. So the drug intervention is one aspect, but there are many systems issues that we need to address. And it comes back to when we talk about the evidence that we have, there's no question that we know that when we look at option A, which is the AZT backbone a regimen for prophylaxis in women who are not in need of treatment, we know that it performs as well as the option B option or the treatment option. The only thing is that you have to put programs in place that are effective, of quality, to have those effects. And we've known for a number of years now that it's not that straightforward in most countries. And the problem most of the times is how the MNCH platform is actually performing. So last year, during the IAS conference, we actually looked at this, UNICEF, Clinton Health Access Initiative, the Business Leaders Council. We looked at the assumptions around how do these interventions actually perform. We also looked at some of the operational barriers. How are our programs using routine data actually performing? And then how does that all impact on what we're trying to do? And it's very clear that when you look at reducing infant infection, if you look at option B, which is triple therapy up to the end of breastfeeding, and you look at option B plus, which is lifelong treatment, the performance in terms of infections averted are almost the same. But then when you look at option A, because of the difficulties that we have in actually identifying those women that don't need treatment and the performance of the CD4 access, you find that the performance of option A operationally and effectively in a program approach is not doing as well as option B. And then when you look at increased maternal life expectancy, you find that again, option B plus is doing much better. And then when you look at transmission to sexual partners, you find that option B plus, because it's lifelong treatment, is actually doing much better. So we have set targets within the global plan to eliminate mother-to-child transmission. And as Craig said, we're actually looking at elimination as a 90% reduction in new infections in low and middle income countries. So the first bar that you see there, that's the 90% reduction. The baseline is 2009, and this is what we had in 2011. So you can see the trajectory of where we need to go to get to elimination by 2015. To actually do that effectively, we are applying a 4-pronged strategy. And here I just illustrate one of the prongs, which is making sure that 90% of pregnant women living with HIV in those countries actually has access to the most effective regimen for prevention of mother-to-child transmission. And if you look at 2009, we're at 16%, and 2011, we're at 48%. Now this is data for the 22 priority countries that make up 90% of new infections in children that have been prioritized within the global plan. We also have targets around maternal mortality reduction. I don't have HIV-related maternal mortality, HIV-related child mortality, and we've set the bar at 50% reduction of that. So you can see that we're nowhere near where we want to be. And I just want to go through what we're trying to do with this project to try and address some of the critical bottlenecks that we see from our perspective. Now, I borrowed this. We just had a planning meeting in Malawi for the 4 countries that are involved in this project, and I was fascinated by this slide that was presented by Frank, who's with us today from Malawi, looking at why Malawi decided to go to B+. And they don't call this a cascade. I think all of us have been talking about cascade. They're talking about hurdles. But because in PMTCT, because of the level at which we are operating, all these points are bottlenecks for us getting a quality program that will give us the results that the research has actually demonstrated to us. So what we're trying to do in the CEDAR project, or the OTA project, which is optimizing HIV treatment in pregnant women, is that we asking the question, if this is a catalytic project and countries are already thinking about what to do, how do we optimize the delivery of a simplified triple ARV regimen for pregnant women and women living with HIV by strengthening primary health care systems? How do we create the demand for women to actually access, so increase utilization and uptake of services, but in a timely manner, but also that we retain these women in care? And the final thing is, what type of monitoring do we need to put in place? How do we get programs, especially at the decentralized level, looking at their data in the long term to try and improve on the quality of services? So the Tanahashi model is something that's been in being for some time, and in UNICEF we're using this model to really look at effectiveness and efficiency of what we are doing. And it looks at 3 points. One is the supply side of things. Do we have the commodities? Do we have the human resources? Do we have the geographical access for these programs actually to be effective? We look at the demand side and we ask, what is the initial utilization like? What is the continuous utilization? And in a lot of countries, you see that ANC access, the first access, is usually high, though later than what would like it to be. But when you look at the fourth access, you look at access to skill delivery or delivery in an institution, that tends to be much, much lower. And then the quality in terms of the services we are providing. And that for us equals effective coverage in a programmatic approach. And so we have developed a tool. It's an Excel-based tool that allows programmers, especially at the decentralized level, to look at their own data, populate the Excel spreadsheet, and channel out charts that allow them to look at where the critical bottlenecks are. I just want to say that to feed into the model, the starting point is to go back to the bottlenecks that I talked about. All those stages that I'm talking about, ANC attendance, HIV testing, become the indicators or tracer indicators that you want to look at. So the first step is to run your charts to tell you which ones of these indicators is performing the poorest, and then you do a bottleneck analysis or a causality analysis around the tracer interventions that you would have identified in the initial stage of your analysis. So basically what this means is that we know that the drug itself, we want to simplify it because we think that's the easiest, not just for the mother, but also for planning and for the provider at the clinic when you don't have enough human capital, and when you don't even have skilled capital to do the job. We're talking about task shifting. We want to make it simple. So this 1 pill once a day is what we're trying to push and what we want to promote. But in addition to that, we're looking at the systems bottlenecks that will allow us to do the job. So is it community engagement to create the demand? Is it about task shifting? And the bottleneck analysis too allows us to look into your program to actually do that. And then what we're then looking at is whether we can have a better program in terms of retention and also infections averted in children. This is an illustrative analysis that we did in Uganda as part of this planning, and here we're looking at ANC, and you can see when we do now the causality analysis, we're looking at, is it commodities, is it human resources, is it geographical access, and is it about the proportion of pregnant women who actually attend ANC, because for us, ANC attendance is very important for us to know the extent to which we can promote testing and ARV access. So you can see, as you go along the cascade, you can see the fall off. But all these drops actually feed into each other. If women are not coming because geographical access is a problem, you're not going to have high ANC coverage. If you don't have high ANC coverage, you're not going to have testing. So all of them feed into each other. So the critical point when you discuss with the program manager, especially at the decentralized level, is where you're going to put your investments. And that's what we're trying to do with the OTA project. So looking at Uganda, because the last illustration, and we ran these charts for all the tracer interventions that we have. And so looking at Uganda, and this is the last slide, you hear from Uganda that a lot of the drug interventions, the facility-based interventions, are already being taken care of by PEPFAR. And what this project is then going to do, looking at the bottlenecks that we found, is that our focus will be how to better link facilities with community structures through the village health worker teams that they already have, active follow-up by lay counselors, and outreach to make sure that mothers are coming early into ANC and also are retained in care. Thank you.
Thanks, Chewe. We're going to have now the community perspective presentation from Sisi Mirembe in Uganda, delivered by Godfrey Esiro, the National PMTCT Program Manager from the Ministry of Health in Uganda.